Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to introduce our project, Practice Pattern and Approach to Childhood Lupus Nephritis in Saudi Arabia. This project done by Dr. Abdulaziz Al-Mutairi, Prof. Sulaiman Al-Mayouf, Prof. Jamila Gari, Dr. Muhammad Nishawi, and myself. I have nothing to disclose. As we all know, renal complication is a major cause of morbidity in SLE, and this is more prevalent in pediatric patients, including our population. However, a variation in the management of these patients had been observed between the pediatric rheumatologist and nephrologist. So our objective is to review the current physician practice and in diagnosis, management, and monitoring of childhood lupus in Saudi Arabia, observing variation similarity to international guidelines and limitation. We designed multiple questions with different clinical scenarios covering more than one aspect regarding childhood lupus nephritis. We did not include question about hydroxychloroquine, as this is the standard of practice, as well as multi-target therapy and other points. The questionnaire was divided into 4 domains, but for the sake of the time, I will mainly focus on the important result regarding general and demographic information, proliferative lupus, the management of proliferative lupus nephritis, and adjuvant therapy. Among 135 physicians, we have response for more than 40% of them. 33 were nephrologists, and 28 were rheumatologists. Regarding the steroid use in the induction management of the proliferative lupus nephritis, 70% will use pulse steroid followed by an oral steroid, 2 milligrams per kg. 50% will start with only oral steroid, and the other 15% will use other regimens. So when it comes to the weaning of steroid after partial or complete response, 18% will stop after 3 months, 30% will stop after 6 months, and the majority will continue on low-dose steroid for longer duration. So regarding the choice of immune suppressive medication during the induction treatment, there is a variation among the respondents. 46% will use cyclophosphamide, and the majority will follow the NIH protocol. 35% will use MMF, 10% will use rituximab, and 3% will use calcinuria inhibitors. When we went back to the result, we found that the majority of rheumatologists in the red color will use the cyclophosphamide, and the majority of nephrologists will prefer to use the MMF. As expected, MMF is the drug of choice regarding the maintenance treatment. So remarkably, only 10% will use rituximab as a first-line treatment. 34% will use rituximab as a second-line treatment. There is no agreement regarding the time of discontinuation of the immune suppressive medication. However, 33% will stop after 3 years, 40% will stop in earlier point, and 25% will continue for more than 3 years. Regarding the adjuvant therapy, 90% will use angiotensin-converting enzyme agent to control the proteinuria, and if cyclophosphamide was used in the treatment regimen, only 33% will use BGB prophylaxis. For girls who are post-menarche, 30% will use gonadotropin-releasing hormone, 7% will use oral contraceptive pills, and the majority will not use any fertility preservation. Regarding SLE disease activity monitoring, 41% will use the SLE disease activity index, and most of them are rheumatologists. In conclusion, the results of our study show considerable difference and individual variation in the management of childhood lupus nephritis in Saudi Arabia. It also shows considerable agreement and some differences with international recommendation. This study is already accepted in the Saudi Journal of Kidney Diseases and Transplantation, and will be published online soon, so you can have a look on the complete results. So what I have learned from this study is the importance of collaboration between the pediatric rheumatologists and nephrologists, and the need of national guidelines, national consensus. So me and my team started this project, Consensus for Managing Childhood Lupus Nephritis, in Saudi Arabia, and this project is under the umbrella of Saudi Society for Rheumatology and Saudi Society for Nephrology and Transplantation. And let me briefly introduce you to this ongoing project. The organizing team are Dr. Abdulaziz Al-Mutayri, pediatric rheumatologist from King Saud Medical City in Riyadh, Dr. Ibrahim Sandukji, pediatric nephrologist from Taiba University in Medina, Dr. Abdulaziz Hassan, pediatric nephrologist from King Abdulaziz University in Jeddah, Dr. Hana Al-Ahmari, adult rheumatologist and epidemiologist from King Khalid University in Abha, and Dr. Muhammad Nishawi and myself from King Abdulaziz University in Jeddah. Our objective is to develop recommendation of the management of childhood lupus nephritis involving both disciplines, the pediatric rheumatologist as well as the pediatric nephrologist, taking in consideration the different region and health system in our country. So this is our task as an organizing team, and this is what have already been done. Another team will be the expert panelists, and we decided to choose as if they have more than 5 years in rheumatology, nephrology, different region, different health system, and has experience in lupus nephritis as an optional criteria. The rheumatologists and nephrologist experts are demonstrated in this slide as they are practice and work in different regions as well as using different health system. We may consider other as external experts, adult rheumatologists, and adult nephrologists. The plan is to arrange an online meeting between the organizing team and the panelists in April 2025, and we will have multiple voting sessions if needed. This project will be the first project conducted in Saudi Arabia involving both disciplines, and hopefully reaching a consensus will improve the quality of care for our patients. And this concludes our presentation, and thank you for listening.
Thank you very much, Dr. Amtinan. Any question for her? Thank you, Dr.
You're welcome.